All right, future nurses, let's jump right into this high-yield explainer on the endocrine system. This is designed specifically to help you master those absolute core concepts for your ATI and NCLEX exams. Now, we know this system can feel incredibly complex, mostly because it literally touches virtually every single cell in the human body. But today, we're going to break it down together. We are going to filter out all that extra noise and focus entirely on the must-know physiology, the critical patient assessments, and those life-saving pharmacology points that you will absolutely for sure see on your boards and out on the floor in clinical practice. To make sure we're getting the most out of our time, here is our roadmap. We'll start with endocrine physiology and feedback, then meet the major glands, cover assessments and diagnostic tests, dive into crucial endocrine pharmacology, and finally, we'll wrap up by nailing some real NCLEX-style questions.
Let's get right to it with Section 1, Endocrine Physiology and Feedback. The absolute #1 crucial concept you have to wrap your head around here is homeostasis. Honestly, the overall mission of the entire endocrine system is simply just to maintain this physiologic stability. I mean, think about everything you encounter in a single day. Stress, massive temperature shifts, changes in your fluid intake, maybe fighting off an infection. Through all that environmental chaos, your endocrine glands are constantly working behind the scenes. They're secreting these chemical messengers directly into your bloodstream just to ensure your internal environment remains perfectly, delicately balanced. Basically, every single pathology we study in this unit is just a failure of this homeostasis.
And this brilliantly shows exactly how your body pulls off that balancing act. It's a hugely complex communication network. Notice the flow here. You've got the hypothalamus sitting at the top, and it's sending stimulating or inhibiting hormones down to the anterior pituitary. Then the pituitary sends its own hormones, things like TSH or ACTH, out to target glands, like your thyroid, your adrenals, and your gonads. And then finally, those target glands release the actual final hormones out into your body tissues. It is just this brilliant, multi-tiered cascade of chemical messengers. You know, the best way to really understand negative feedback is to think about the thermostat in your living room. This is exactly how the body prevents these hormone cascades from just spiraling totally out of control. So just like your home heating system, negative feedback stops hormone production when the levels get too high. If the room gets too hot, the thermostat clicks the heater off, right? Well, in your body, if cortisol levels get too high, your brain senses it and immediately shuts down those stimulating hormones. Now, on the rare flip side, we have positive feedback, which actually amplifies the signal. This means high levels stimulate even more hormone synthesis, a great example being oxytocin during childbirth.
Okay, moving right along to Section 2, meet the major glands.
So, starting from the pituitary, which we pretty much always call the master gland, up there in the brain, all the way down to the reproductive organs, these glands are secreting hormones directly into your bloodstream. You've got the pineal and pituitary in the head, the thyroid and tiny parathyroids in the neck, the adrenals sitting right on top of the kidneys like little hats, plus the pancreas and the gonads. And remember, because these glands lack ducts, they are heavily vascularized. The bloodstream is essentially their superhighway. When we contrast these distinct anatomical locations, their specific roles really start to make sense. For example, the thyroid in your anterior neck is pumping out T3 and T4, which is basically the gas pedal for your overall metabolic rate. Contrast that with the adrenal glands located right above the kidneys. The inner part, the adrenal medulla, handles your acute, immediate fight-or-flight stress response by dumping out adrenaline. Meanwhile, the outer adrenal cortex handles your long-term survival, using mineralocorticoids like aldosterone to manage your fluid volume and glucocorticoids like cortisol to manage inflammation. Let's transition into clinical practice with Section 3, Assessments and Diagnostic Tests.
Now, before we look at specific disease processes, please keep in mind that our older adult patients are operating with a shifting baseline. The absolute highest yield point you need to know here is their diminished response to ADH, or antidiuretic hormone. Because their aging kidneys are just less responsive to it, they physically cannot conserve water as easily, which makes them highly vulnerable to profound dehydration. You're also going to see natural declines in growth hormone, changes in how they clear cortisol, and a much higher prevalence of hypothyroidism as they age.
Listen up, because this right here is an absolute classic NCLEX trap. The parathyroid glands control calcium. When those glands fail, or say they're accidentally removed during a thyroid surgery, the patient's serum calcium plummets. Since calcium is essential for nerve and muscle function, when it drops, the muscles become super hyperexcitable. You have to know exactly how to elicit the two hallmark signs of this hypocalcemia:
First is the Chvostek sign, which you test by tapping the facial nerve and watching for a facial spasm. Second is the Trousseau sign, where you inflate a blood pressure cuff on their arm and watch for this very specific spasm of the hand and wrist. Do not mix those two up.
Look, I know the diagnostic tables in your textbooks are just massive and overwhelming, but focus your studying right here on these high-yield labs that confirm overactive or underactive gland function. For the pancreas and diabetes, the A1C gives you that critical long-term index of glucose control, with a target usually under 7%. For the thyroid, remember the seesaw effect of negative feedback. Serum TSH actually increases when the patient has hypothyroidism because the brain is essentially screaming at a lazy thyroid to work harder, and it decreases in hyperthyroidism. Finally, measuring serum cortisol helps us pinpoint adrenal function, testing for dangerous hypersecretion or hyposecretion.
Next up is Section 4, Crucial Endocrine Pharmacology.
The cool thing about endocrine pharmacology is that the logic is actually pretty straightforward. Because this whole system relies on chemical messengers, when something goes wrong, we really only have a few options. We either manually replace deficient hormones, suppress excessive ones, or we just manage the symptoms. For instance, if the thyroid fails, we simply give synthetic levothyroxine. If the pituitary is pumping out way too much growth hormone, we use a suppressant like octreotide. If the pancreas fails, we carefully regulate the glucose with insulin or oral agents like metformin. And of course, we frequently leverage those powerful synthetic glucocorticoids to suppress severe inflammation.
Let's just pause for a second. There is a massive, blinking red flag when it comes to those adrenal hormone therapies we just mentioned. If you are caring for a patient taking a glucocorticoid, like dexamethasone or prednisone, there is a strict life or death rule you absolutely must understand, both for your exams and for your actual patient safety. You have got to relentlessly educate your patients on this point. Never, ever stop taking corticosteroids suddenly. Why? Well, think back to our negative feedback loop. When you give a patient artificial steroids for a long time, their body's natural adrenal glands sense those high levels and essentially go to sleep. If you abruptly withdraw the medication, those adrenal glands are still dormant. The patient is left with absolutely zero cortisol, which is a life-sustaining stress hormone. This triggers a fatal adrenal crisis, leading to profound cardiovascular collapse. You always taper these drugs gradually.
All right, time for the fun part. Section 5, Nailing the NCLEX questions.
Let's put all this knowledge to the test and see how it actually looks on an exam. Understanding the fundamental why of the endocrine system is the absolute key to mastering these physiologic adaptation questions on your boards.
So, here's our first question. Based on what we covered at the very beginning of this explainer, how would you answer this? Is the primary overall mission of the endocrine system electrolyte balance, metabolic rate, maintaining homeostasis, or resisting infection?
If you said C, you hit the nail right on the head. Now, obviously, the endocrine system certainly influences metabolism through the thyroid, and it influences electrolytes through aldosterone, and even the immune response through cortisol. But maintaining homeostasis perfectly encapsulates its entire overarching physiologic mission. It is the big umbrella term that covers all those specific jobs the individual hormones perform to keep the body's internal environment stable.
Awesome. Let's tackle one more. And this one ties right back to those age-related changes we talked about earlier. Remember our conversation about ADH, or antidiuretic hormone? If an older adult's kidneys have a reduced response to it, what is the most significant clinical consequence?
The answer here is definitely number 1. Because an older adult's kidneys are just less responsive to antidiuretic hormone, they physically cannot conserve water as efficiently. They can't easily compensate when they sweat too much or if they happen to drink too little. This makes choice 1 an increased risk for profound dehydration, the clear and present danger here. And this is exactly why you have to closely monitor intake and output, as well as mucous membranes, in all your elderly patients.
I want to bring it back to this one foundational quote from the text. Remember this, because as a nurse, your primary day-to-day responsibility is to monitor, assess, and intervene to protect this delicate balance. Whether you're administering insulin for a failing pancreas, checking for Shavquistic sign in a hypocalcemic patient, or educating someone on why they need to taper their steroids, you are literally acting as the external regulator for a body system that has lost its internal equilibrium.
So, as we wrap up this explainer, I want to leave you with something to think about before your very next clinical shift. Ask yourself, what subtle signs of endocrine imbalance are you going to be looking out for today? Will it be that patient with unexpected weight changes? Or maybe the elderly patient who is highly prone to dehydration? Keep this homeostasis framework in the back of your mind, and you won't just ace the NCLEX, you'll catch critical patient deteriorations way before they happen. keep studying hard, and we'll see you in the next explainer.